Neonatal jaundice is the commonest cause of pediatric admissions or neonatal admissions. Jaundice is not exclusively found in babies, neonates. Jaundice is found in all ages.
Neonatal jaundice is a very common disease among newborn babies. It is characterized by yellowing of the skin and then the eyes. Today on the Health Focus show, we'll be talking about neonatal jaundice. We'll be knowing exactly what it is. I'm Elliot Aitenuete. I'll be your host for today's show, and to help me with discussion, I have with me Dr. Edward Akosa Danso. He's a medical practitioner with the Ghana Police Hospital. Welcome, Doc.
Thank you very much.
Yes. Before we talk about what neonatal jaundice is, let's look at what jaundice is in general.
Okay. Jaundice is a medical term. That's a very simple definition. Yellowing of the eyes and the skin, especially in newborns. So basically that's what jaundice is. Yellowing of the eyes and the skin. And when we talk about, let me add on to that. The neonatal period from birth to 1 month. So when you combine both words, yellowing of the eyes and skin in a baby who is between 0 and 1 month old.
We'll come back to neonatal jaundice, but is it only a disease that happens to children? Because it happens to be that neonatal jaundice is popular when we are talking about jaundice.
Okay. So jaundice is not exclusively found in babies, neonates. Jaundice is found in all ages, in all age groups, in men, in women, in babies, in adults, in children, in the geriatric population. And in adults, usually, jaundice is a sign that points to something deeper.
Okay.
So in adults, jaundice is reflecting another disease.
Okay.
So, in adults, we say neonatal jaundice. In adults, we always say jaundice is secondary to something. So, jaundice secondary to liver failure or a liver disease. Jaundice secondary to, let's say, sickle cell hemolytic crisis. Jaundice secondary to maybe an obstructive pathology in the liver. So, jaundice, in essence, is a sign of another disease.
Great. That's very insightful. Now, what's so peculiar about the neonatal jaundice?
Okay. Neonatal jaundice is the commonest cause of pediatric admissions or neonatal admissions.
Okay.
So, is the condition that takes babies, that's babies between birth and 1 month, to the hospital. 6 out of 10 babies who are born at 10, that's 37 weeks and more, will have jaundice. And 8 out of 10 babies who are born prematurely will have jaundice. And what makes it more important is that it can cause, someone will ask, why are we talking about jaundice? Why are we talking about jaundice? It can cause brain damage. It can cause death. But that's not the most important thing about jaundice. That complication is totally preventable. That's what makes it more important. That's why we dedicate a month to it. Because it's something that can cause brain damage, can cause death. It's the most common presentation in neonates. And its complication is totally preventable. That's why we keep on making noise about it. It's common, it's dangerous, it's preventable. That's why we talk about it.
Are there types of neonatal jaundice? I'm asking this question because you made mention that 8 out of 10 babies who are born prematurely have a higher chance of having the condition of neonatal jaundice, and then 6 out of 10 babies who are born within normal times have the condition. So, are there any differences or kinds of neonatal jaundice?
Okay, so to answer your question, I'd have to go into what causes jaundice.
Okay.
In order to tell us how we can classify it. So in you and I, we have red blood cells that are usually broken down. they are broken down to form bilirubin and some other products
Okay.
that we wouldn't talk about. The bilirubin, it's usually carried to the liver and it's excreted through the stool. Simple terms.
Okay.
So when our liver, and so the liver processes the bilirubin for excretion, and it's the bilirubin that causes the jaundice. So high bilirubin level will give you jaundice. I hope you understand that.
Yes.
And the liver processes the bilirubin for it to be excreted out of the body. So if there's a problem with the liver, the bilirubin will build up. I hope you are following.
Yeah.
So in neonates, that's children or babies, their conversion ability or the activity of their liver enzymes are not as mature as adults. So they can't convert the bilirubin to an excretable form. That's one cause. That's the first cause.
Okay.
So because babies or neonates are inherently unable to convert the bilirubin to an easily excretable form, it easily builds up. So that's what causes neonatal jaundice.
Okay.
Then we can classify that as physiological because there's essentially nothing wrong with the baby. It's just because the system is now developing. So we call that
system at the moment cannot make
so
use of
the baby is fine.
Okay.
So we call that physiological jaundice. But then when there are other causes, let's say blood group incompatibility, the mother is rhesus negative, the child is positive, more or less the antibodies are fighting each other, causing the red blood cells to break down faster than they are supposed to. So already the baby can't excrete. Now you are adding more. So we call that pathological jaundice.
Okay.
I hope you get the two.
Yes. So let me try and see if I can simplify what you said. So with the first type, which is the physiological, it is as no fault of the child.
Exactly.
At the moment, their system cannot make good use of the bilirubin
To excrete it out.
Exactly. And then with the pathological is as a result of a fault, maybe from the child or from
blood group incompatibilities, other enzyme deficiencies.
Yes.
And the reason why the classification is purely academic, when you come to clinical setting, we really don't say this is physiological jaundice, this is pathological jaundice. We just say neonatal jaundice.
Okay.
It's because the treatment is essentially the same, and we usually can't. It's usually prudent to treat them, to give them the same level of attention, because regardless of whether it's a physiological process or a pathological process, if the bilirubin is high, it can poison the brain and kill the child or cause brain damage. So this classification of physiological, pathological is purely academic. It's for exams. But when you're in the clinical practice, you'd actually, if your baby has jaundice, you actually try to find out whether there's a blood group incompatibility, there's an enzyme deficiency or whatnot. But essentially, you manage your child whether it's physiological or pathological. So the classification is there, but it's just for exams and purely academic. Clinically, we treat them the same, and we manage them as aggressive as whether it's physiological or pathological.
Earlier, you mentioned that neonatal jaundice happens within the first 1 month of a child. At what point after childbirth do you diagnose it, and what are the indications you look out for in a child to be able to detect that this particular child may be suffering from neonatal jaundice?
Okay, so from birth to 1 month,
okay,
you can diagnose it within any window. At birth, once the child is delivered, whether via an operation or not, you examine the child, you realize that there's yellowing discoloration of the eyes or the skin, you have your neonatal jaundice. You do some labs to confirm it. The child might be fine at birth, the child will be discharged, will go home and come back. You go home, the mother would realize that the eyes or the skin is yellow, come back, you diagnose jaundice. So it doesn't really matter whether it's day 1, day 0, day 30, up to day 30, it's still neonatal jaundice.
Great. Let's look at the causes. Now you've explained by means of the types what causes it, but do we have other risk factors that can result in neonatal jaundice?
Okay. The first one, like I explained, is the physiological in quotes, when the baby is not able to break down the bilirubin like the baby is supposed to. Then we have another common cause is blood group incompatibilities.
Okay.
So, not to go too much into immunology, we all have blood groups. I don't know if you know your blood group, but I'm B positive.
Okay.
So we have the ABO blood groups and we have the resource blood groups. Usually, the resource groups, so mothers who are negative, and if a mother is negative and the father is positive, and the child that's in the mother's womb is positive, sometimes some of the blood can cross, mother and fetal blood can cross.
Oh, okay. So if you say blood group compatibility, incompatibility, it is just the mother and then the child, not
Yes.
say mother and father.
Just the mother and child. Just the mother and child. Okay. So the mother's blood group and the baby's blood group. The resource factor. If the mother is negative, the baby is positive, there's a high risk of having neonatal jaundice. Okay. If the mother's blood group is O positive and the baby has any other blood group, there's an increased risk, albeit lower risk than resource incompatibility. Okay. That's a cause of jaundice. Then we have some enzymes, an enzyme called glucose-6-phosphate dehydrogenase. It's an enzyme that usually breaks down oxidant species. So oxidant species are let's say metabolic products that can affect red blood cells, can affect any cell in the body. So they break down the red blood cells, like I said, to produce the bilirubin. So if you have this enzyme deficiency, this enzyme is supposed to mop up the reactive oxygen species. If that enzyme is deficient, then the ROS, the reactive oxygen species, tend to break down red blood cells faster than they are supposed to, tend to increase the levels of bilirubin and cause jaundice. Okay. Then there are other rare causes, like some inborn errors of metabolism, like galactosemia. They are quite rare. They can also cause jaundice. Then there's also breast milk and breastfeeding jaundice. There are two opposite causes, two opposite etiologies. When we talk about breastfeeding jaundice, so I think I mentioned earlier that the bilirubin is supposed to be broken down or converted by the liver, then excreted out. In children who are not being breastfed well, or the feeds are limited, the bilirubin is supposed to go through the gut and come out through the stool. But if you are not breastfeeding well, there's no food in the gut to come out. There's no food in the gut to come out. So you realize that the bilirubin is staying in the gut and being reabsorbed into the blood. So that causes the breastfeeding jaundice. And in some women, there's an enzyme in the milk that can convert the already converted bilirubin back into something that can be reabsorbed into the blood to cause the jaundice. Yeah, so these are some of the common causes of neonatal jaundice.
Well, that was very insightful. Let's go for a quick break, and then when we return from the break, we'll talk about the neonatal jaundice gotten from breastfeeding, because it happens that traditionally some mothers use breast milk to treat jaundice in their children, and you are telling me that breastfeeding can cause neonatal jaundice. So after this quick break, we would look at it. Now let's go for a quick break. When we come back, we'll look at how breastfeeding can cause neonatal jaundice in children. Yeah, welcome back to Health Focus on Ghanaweb TV. I'm Elliot Aitenwete, and I have with me here Dr. Edward Akosadan. So he's a medical practitioner with the Ghana Police Hospital. Doc, before we went for the break, we were talking about how breastfeeding can lead to neonatal jaundice in children. Can you touch on that? Not briefly, because strangely, some mothers tend to use breast milk to treat neonatal jaundice in their kids.
Okay. So it's quite a paradox, if you ask me, that giving breast milk can cause jaundice and not giving breast milk can also cause jaundice. The most common one is the not giving breast milk. So, like I explained earlier, not giving breast milk can cause the bilirubin to stay in the gut, will be reabsorbed into the blood and cause jaundice. Then, if you give more breast milk, it causes the bilirubin and everything to be excreted faster, and the jaundice will go away. Then we have the other side where giving breast milk can cause jaundice, and that's what we call breast milk jaundice. And I should mention that breast milk jaundice is a diagnosis of exclusion. When we say something is a diagnosis of exclusion, it means once you've exhausted all other causes of the jaundice and you've examined all the systems of the child, of the baby, and everything is fine, and the child still has jaundice, and once you stop the breast milk, you realize that jaundice is clearing up, then you can confidently say that we have breast milk jaundice. So what causes breast milk jaundice is the fact that some women have an enzyme in the milk that reconverts the bilirubin back to its form that can be reabsorbed from the gut into the blood, and lead to the yellowing, discoloration of the sclera and the eyes. It's not very common, I should say, but then it's there. And what we should keep in mind is that once you have neonatal jaundice, you've tested everything, the woman is breastfeeding adequately, so you know there's no breastfeeding jaundice. You've tested the liver, you've tested everything, but still the baby is jaundice, you know there's breast milk jaundice. And if you test the baby's bilirubin level, you examine all the systems, the liver, everything is fine, the baby is active and playing well, you can tell the mother to continue breastfeeding. It's a self-limiting condition, usually resolves after 12 weeks, and requires adequate monitoring. So once the bilirubin level is not too high, not in the phototherapy level, the child is out of the first 2-week period, you can let the woman continue breastfeeding whilst monitoring the serum bilirubin level. And after 12 weeks, usually it will self-resolve. But then, if the breast milk jaundice, you check the bilirubin level is extremely high, the child requires phototherapy. When you stop the breastfeeding, the bilirubin level goes down. But when you start again, it goes very high again, the child requires phototherapy again. Then you'd be thinking that, okay, this is someone we can't do breastfeeding. We'd have to find other alternatives. Especially if it's between that period where it can cause the brain damage. So that's it for the breastfeeding. It's quite a paradox if you ask me. But then, like I said, it's a diagnosis of exclusion. You have to rule out all the other causes. You know, infections too can cause jaundice. Rule out all the other causes of the neonatal jaundice. Then you can confidently say that this is breast milk jaundice, and we can either continue the breastfeeding and monitor. But if it's getting to levels where it might affect the child's brain, then you have to hold it.
Since we've touched on some traditional ways parents use in treating neonatal jaundice, can we look at how safe it is? Now, there are some people, prior to this interview, I did some readings, and then some people say that they use pawpaw leaves to bathe their child when they detect that their skin is yellowish to cure neonatal jaundice. Some also say after bathing their child with a pawpaw leaf, they give them some to drink. And I understand that at that period, at the first 1 month after birth, children are supposed to take, if anything at all, just the breast milk. How dangerous is it?
So let me also add some. Some also pour the breast milk into the child's eye. I've heard of that. So they have no evidence in literature that they are effective, and they might actually be deleterious, because pawpaw leaves, the child's guts, that's the intestines, they are not used to something as harsh as that. So it might affect them negatively than help them. Its effectiveness is not documented. There's sunbathing, where women were advised to take their children out into the morning sun, the jaundice might clear. If you are lucky and it's physiological jaundice, the levels aren't high, the jaundice was going to clear on its own. When you taking that child into the sun might work. But then here's the case. I read something recently that, let's say you see a woman who has a long dress, a very, very long dress, and the woman is wearing a high heel, and the woman is very tall. Would you say that the woman is naturally tall, the high heel that's making the woman tall, especially with the long dress covering the legs? What would you say?
It will be very difficult.
It will be very difficult. So if you see a child with jaundice, it will be very difficult to say that this is physiological, this is pathological. Physiological, oh, it will go. Let's just monitor, let's just continue the breastfeeding. This is pathological, we need to treat. Very, very difficult. You have to take the child to the hospital. So all these practices, now that we have evidence-based therapy, I'm sure you'd ask me about how we manage it. We'll get there. Now that we have evidence-based therapy to manage neonatal jaundice, I believe that it's in our interest and the interest of our mothers to bring the babies to the hospital for us to manage, because we honestly can't tell the difference.
I would want to draw you back to the traditional method, because most often if you look at the family setting, then people who advocate for this traditional means, it is the grandparents, those who are more in touch with their roots and then their herbal life. I don't know if that is the best way to put it, because they claim that it has been working over time, and even at a time where we didn't have medical knowledge and the medical technology, that was what they were relying on, and that was what was helping. Don't you think that it's about time maybe the scientific world look at some of these traditional means to see if indeed they are potent, or like you are saying, it's just a coincidence? Most of these children who were taken through this process just had the physiological jaundice and then they are cured.
Well, the jury is out, but I believe that something that's I know definitely is deleterious to the baby's guts, like the pawpaw leaves, drinking it. That I wouldn't say we should look into. Yes, I think that's a no-no. But other things, the sunbathing, if it's physiological, will work, honestly. If it's pathologic, and you can't tell the difference. So I'm sure during those times, they had more physiological causes. And the reason being that I know someone who was rhesus negative. That's the blood group.
Okay.
Rhesus negative had recurrent miscarriages because the blood mixed up in utero. So once she gets pregnant, she loses the baby. So she never had a child. That's an older person. I know someone who's rhesus negative who has 4 children. So in those times, possibly the person with rhesus negative never had a child to have pathological jaundice. By recent times, with something called ROGAM, where mothers who are rhesus negative can have children with a reduced risk of neonatal jaundice, might have children who have pathological jaundice who need to be treated. So in those times, they weren't, I'm tempted to say they weren't having a lot of pathological jaundice. That's why those things the sunbathing was working. But now we know that pathological jaundice is there. There's a thin line between that and physiological jaundice. And if you can, why not bring the child to the hospital?
Before we look at the scientific and then the medical treatment, I would want to know that, is it possible to detect if a child is predisposed to neonatal jaundice from the, is it antenatal period?
Oh,
antenatal
definitely. It's very, very possible. Not even the neonatal period. A woman who has the firstborn having neonatal jaundice is likely to have a secondborn having neonatal jaundice, because the risk factors that cause the firstborn to have the neonatal jaundice is probably present in the secondborn. So that's why we take a history, we do some labs and find out. If you look in the neonatal book, there's a part, there's blood group, ABO blood group, there's resource factor, there's G6PD status. So they test the woman for all those things. So if I'm seeing a woman who is in labor or who is due maybe next week, and I know the woman is resource negative, I have it at the back of my mind that this baby is at risk of having neonatal jaundice. I have to look out for it. If the baby doesn't have neonatal jaundice at birth, I would counsel the mother to look out for it and come to the hospital as soon as possible. If a woman, because G6PD is X-linked recessive, if a woman has neonatal jaundice, if a woman has G6PD deficiency and has a male child, my interest is piqued in that child because that child is at risk of having neonatal jaundice.
So is it okay to say that neonatal jaundice can be hereditary?
No. When we say hereditary, then we have a genetic basis.
Okay.
I can say sickle cell to some extent is hereditary.
Yes.
Because you inherit defective genes. I can say to some extent albinism is hereditary because you inherit some specific genes. I can say to some extent that baldness or male pattern baldness is hereditary because you inherit some specific genes. But then with neonatal jaundice, we will classify it as risk factors. So the woman or the baby has a higher risk, not an inherited risk.
Okay.
I don't know if you understand.
Yeah, I get it. Now let's go to the treatment. How is it treated? And how do you detect? I don't want to believe that any child who is having what is close to a yellowish skin would outrightly be classified as a child suffering neonatal jaundice. So how do you detect it, and then how do you treat it?
Okay. So when you come to the hospital and you're a mother, you're a father, you realize that your baby's eye or skin has a yellowish discoloration, we'll do some labs. Okay. We'll take the blood, take it to the lab to check for the serum bilirubin level. We have a reference range. Once it's higher than that reference range, then we can confidently say that this is neonatal jaundice. So then we have a diagnosis. Okay. Once we have our diagnosis, we decide whether to treat or not. Then we have something called a phototherapy chart. So every day, let's say on day 1, your bilirubin level is supposed to be this value. On day 2, it's supposed to be this value. On day 3, it's supposed to be this value. Then we plot it along that axis. We have a line, and if your value is above that line, then you need to have phototherapy for that day. So a child that's, let's say, 7 days might have a high value. Or let's say a child at 1 day and a child at 7 days might have the same value. But the one who's 1 day old will need phototherapy. And the one who's 7 days old will not need phototherapy. Then we have another graph that shows that we plot higher levels or high bilirubin levels. And with that, we move from phototherapy to something called exchange transfusion. It's a modality of managing severe neonatal jaundice. I think we'll get to that. But the mainstay is phototherapy. Okay. Mainstay is phototherapy. In severe jaundice with higher values, then exchange transfusion comes in.
What is that? What is exchange transfusion?
So let me talk about phototherapy first, because that's what most people would have. So with phototherapy, I don't know if you recall that bilirubin is toxic to the brain. Bilirubin is in the blood. We need to get bilirubin out of the blood, excreted either through our urine or through our stool. The light will convert bilirubin to a form, another form that is non-toxic, that can be easily excreted. Basically, that's what phototherapy does. Converts the bilirubin to a form, is non-toxic, and can easily be excreted. There are three main ways it does that. There's photoisomerization, there's structural isomerization. I wouldn't really go into that. But then, basically, we'll convert bilirubin to a form that can be excreted, can get out of the body, so it doesn't poison the brain. When we have very high levels that we need to act very fast, there's something we call exchange transfusion. The bilirubin is in the blood, right?
Yeah.
We want the bilirubin to get out of the blood. But using the photo, comparing it to the value we have, will be quite slow. So, in very simple terms, we remove all the baby's blood and put another blood inside.
Wow.
I don't know if you understand that.
Yes.
So that's exchange transfusion. So we get all the bilirubin out, bring new blood that has normal bilirubin levels, so there's nothing to poison the baby's brain.
And then do the transfusion.
So that's what we do for very severe jaundice. Yes. But then most people would have the phototherapy. The phototherapy works. Okay. It works magic.
Okay. So like you mentioned, neonatal jaundice can be diagnosed within the first 1 month.
First day.
Yes, even the first day. Yeah. But then there's a chance that at birth some children may not show signs.
Yes, possible.
And they will show signs later on when they are at home.
Yes.
Why is it necessary that immediately they witness it, or a parent sees a red flag, they immediately bring it to the hospital? Because there are some parents who would say, oh, traditionally for me, the moment I bring my child from home to the house, it must to the house. It must take 7 days before the child will come out. What do you have for those parents?
Okay, so the main reason it's important is because neonatal jaundice can cause an easily preventable sequelae called kernicterus. Kernicterus is bilirubin encephalopathy. In simple terms, causes brain damage. Okay. So, why we are scared of neonatal jaundice is because it causes brain damage. It can cause death. And why we think it's very important to bring the child as soon as possible is because that complication can easily be prevented. So, we don't want the complication to happen. What can we do for the complication not to happen? We can do phototherapy. And that complication will not happen. Okay. So, that's why it's very important. And the brain damage might not be apparent in the neonatal period, might not even be apparent in the first 3 or 6 months. It's when the child is supposed to sit. You realize, oh, this child is not sitting when the child is supposed to sit. The child is supposed to crawl. The child is not laughing. The child is not smiling. So it won't be apparent to you in the first month, first 2 months, first 3 months. But when the child is supposed to achieve some milestones, then you know that, okay, this child is not developing. Then we'll trace it back and realize that, oh my God, the child has bilirubin encephalopathy, something that could have been prevented with jet blue light. Wow. So that's why it's important, basically.
All right. Thank you very much, Doc, for your time with us today. So it was all about neonatal jaundice with Dr. Edward Akosa. So he's a medical practitioner at the Ghana Police Hospital. My name is Elliot Aitenwete. Let's meet same time next week.